Hi, everyone. Everyone's awake? Let's see.
Thanks.
You did well, Borshika. Everyone stayed awake.
Good.
So that's my title. The messier it gets, the happier I feel. I started out in cell biology way back when, and I'm about as far away from controlled studies of viruses in petri dishes as you can get now. And so the messy part is what I want to talk a little about. So this is opposite of what I think. So I like this quote, change the pronouns. But here we are, thinking about all of our discoveries. I think we're all really lucky to be working in this area of science and discovery, but our cup runneth over when we're thinking about our practical applications. And so I'm going to talk a little bit about some practical applications, at least some studies involving practical applications for some of the work that my teams have been doing over the last few years. And I'm going to talk about a few challenges. Did we already do the 17-year, 13% thing this morning? Okay, so you know the basic challenges, that we got this long kind of leaky pipeline out there, right? And so we'll talk about that. I'll spend a little bit of time talking about a few vignettes from our work. And this is about mostly with public health agencies, state and local health departments. But if you work in clinical practice, I want you to think about how this might apply just as equally in clinical practice, because I think almost every one of the issues I'll talk about, there's a direct parallel with clinical practice. And then my 3 lessons. There's actually a lot more than that. So anyone know about Apollo moonshot? Anybody remember? Those of you old enough to know what Apollo was. There used to be this part with Apollo, and then when I got in trouble with Houston, we have a problem. And you could say that about this 17-year pipeline. We have a problem. The pipeline is leaking. You've got a lot of discovery going over here. We're spending $30 or $35 billion a year on health research. When you get to the other end of the pipeline, of the application of it, we have a problem. There's some leaks along the way that need to be fixed. I'll give you a couple examples of the disconnect for public health agencies. The left column is a study that we're just starting to publish now with local health departments. This is about 500 leaders of local health departments. We asked them how they learn about the latest research findings, and you can see the list here. The right side is about 250 of the leading public health researchers in the United States. We asked them the most effective ways that they reach practitioners. What do you see with these lists? Is there any problem there? And actually, the journal articles is a pretty distant fourth on the left side, and it's a very leading number 1 on the right side. And so you can see those lines don't exactly connect up the way we would like them to connect up. And there's a lot of other bits of data from the survey, but I thought this was one that illustrates well the disconnect. Another disconnect that's at a level, so we have state public health, we have local public health. Most of you heard of the Guide to Community Preventive Services? How many have heard of this? So this is the parallel to the clinical guide, the U.S. Preventive Services Task Force, for public health or population level interventions. It's sponsored by CDC. It gives evidence-based recommendations basically about what public health should be doing. This is just differences, and this is in the physical activity part of the guide. This is just the difference from going from the state health department to the local health department, parallel in time, same survey, and you can see how different it is in the uptake of these evidence-based practices from state to local public health agencies. So there's another practice difference. So now a few short vignettes. This is the data on the community guide, and this is a study that we completed a few years ago, a CDC-sponsored study. And the basic idea was to look at ways of more effectively disseminating the evidence-based recommendations in the community guide. You can see at the bottom here the objective of the study listed. We worked with, and here the sort of unit of analysis here is a big one. It was 8 state health departments. So the 8 treatment sites are state health departments. We had 8 control sites. And we started with sort of a national survey. So we actually surveyed the whole nation to start with, and then a number of the larger local health departments. We used a RE-AIM kind of framework with sort of diffusion of innovation in there as the method of moving through, knowing that about what moves innovations along the continuum. And then our stakeholders here were public health department leaders, people who had worked in health departments, who were currently working. We had an advisory group set up to help guide the project. And then with our 8 states, we had sort of local people appointed in each state to advise us as well. The main intervention here was a training intervention. Some of you may recognize David Satcher here. We managed to sort of kidnap him for a day and got him to do this is a physical activity study, and David is very active. And so we got him to kind of kick off the training and the video for this, talking about his own commitment to physical activity. And you can see the one about dancing here. You know, about dancing can be tough. This is a Far Side cartoon. We learned some of the same things about these interventions. You have to show people the advantage. You have to apply the Rogers diffusion, that you have to break down the intervention, the implementation of it in ways that practitioners can implement it, the complexity. So our training took into account a number of these factors that derive largely from Gary Larson and the Far Side. No, actually more from Ev Rogers and diffusion of innovation. We found awareness. There was we started at a lower baseline of awareness of these recommendations at the local level, and awareness jumped up more at the local level. So you could say that there was more room for improvement there. The later re-aim sort of variables, adoption, implementation, those improved more at the state level. We saw general patterns. We didn't see a lot of statistically significant changes, but we saw some things that helped inform that. So that's sort of part one in one health department study. The other one we're working on right now, that I just want to give one little bit of example from the data. The data aren't even fully analyzed yet, is working at a larger scale. It's kind of a bigger version of the first one. It's a cancer grant. It's working on sort of scaling up cancer interventions with public health practitioners. And the measures are not well developed, so we've got a number of steps here of developing the measures across a framework. We did cognitive testing. We've done reliability testing. We're now doing structural equation modeling. And we're also working on a separate part I won't say much about. It's sort of the parallel to the medical record audit, the public health record audit. Can you get into records and sort of document what a public health agency is doing? It's really messy, but we're trying to do it, and we'll see where it ends up. I want to tell the story. We started off this study with a sort of a version of the re-aim framework that we had already studied in a smaller study that sort of has these stages and some of the contextual factors affecting the stages. And we organized our measures according to that framework. And we ran the structural equation modeling here. You don't need to care about these, but these are just the factor loadings. And the framework didn't work at all. Basically, what we wrote in the grant didn't work. So what do you do? We had long discussions. We had discussions with our team, with other experts at the Cancer Institute, other places, and we decided we needed to change our framework and see if we could find a reasonable framework that would work better. And so we found this one, which is from Canada. You can see a lot of the Canadian terminology of knowledge exchange and knowledge transfer. And if you look at just some of these bigger factors of sort of the main headings, these basically load up to be the factors. And this framework, which was not in our grant at all, is what we ended up and what we're going to plan to use in the larger study. So it shows kind of, you know, what you start out with may not be what you need to end up with, and you need to maintain some flexibility. I would have never written this grant to say, oh, by the way, if this doesn't work, we'll try a different framework, but that's what we ended up doing. So, three little nuggets, three little lessons, I guess, that probably aren't rocket science, but the first one is to, rather than run away from the messiness, sort of embrace the messiness, that's the real world, as Borshig just told us. And so think about the methods of measurement, the designs that will help you sort of embrace this messiness. And these are just some examples. You've already heard from Arnie earlier about social network analysis, systems approaches, agent-based modeling, quantitative measures, and then don't forget about qualitative methods as well, or mixed methods approaches, which I see Borshig has said I think was about 30% of the grants had used those. And I think that could be a real advantage in a lot of these grants, especially depending on the stage of where your D&I research is. Think about things that aren't academic. He didn't publish, so he perished. the listing of that disconnect between practice and academia might lead us to think we need some different intervention strategies than just trying to connect them up to our journal articles. And so this may not come as much in the early measurement part, but it might come about what your implementation strategies are the strategies that we think we would do to get promotion and tenure not well connected at all to what the impact is out in the practice world. And I think this notion of impact and what it means beyond academic impact, a lot of us here work in academia, and so our impact naturally is sort of the journal article, and I think for practice that's not the right measure of impact. So that's another one to think about. And then this notion that you've already heard about of practice-based research, think about what's already going out in the world that you can evaluate through a natural experiment, taking account of what's going on. It's going to be messy, but it might tell us a lot more about what some of the most innovative things going on, which are often not well evaluated, but if we do a decent evaluation, the concept of evaluability assessment plays into this really well. We can end up with some really important new knowledge. Larry Green has written a lot about this, so I put one citation at the bottom from Larry's work. And this is especially important in, I think, lower resource settings with disparities, international settings, where there are big problems, there are things going on, but there's not an infrastructure for evaluation. So think about that, because it can not only add to the knowledge base, but it might be able to address some of these issues in areas with high disparities and high need. That's me, so I think that's my 10 minutes. Thanks.